So what is that?
Bladder?
Your urinary bladder.
What if you're trying to view like the coccyx though? Like,
Okay, so
what if there's like a fracture?
okay, so one of the preps that we do for a coccyx is that the patient has to empty their colon. Yeah, so that's one of the criteria, patient prep. Is so if it's routine, we'll say NPO after 7 o'clock. Okay, we'll see you the next day. We've got to make sure that your bowels are empty. We want you to go to the bathroom before you come and take your x-ray, and then we'll shoot it this way. So the bladder should be empty. Now the AP view is not always going to be the good view. Then we'll do a lateral, which is more telltaling, no pun intended, more telltaling in the lateral, because it's projected from the rest of the anatomy. Okay? All right. So we'll talk about it more towards the end of the semester. Okay. Without looking at this, okay, what are the 3 hip bones?
Ilium,
ischium, and
pubis.
pubis. Okay. The very top of, so what bone is this? Ilium. What do we have here?
Iliac crest.
Crest.
The anterior, superior,
anterior.
iliac spine.
Here as is. Okay, as is. You're not going to see the pisses. Okay, you'll have the as is. All right. This is also a structural area that you need to be familiar with. When looking inside the brim, these 2 bones that project
Ischial spine.
medially is your ischial spine. Okay, so you be asked to label that in a pelvic examination. What is C?
Is that the body? Yeah.
Okay, now I need to look up because I don't know what it's asking
Yeah.
for. Body of ischium. Okay, body of the ischium. F and G. F and G.
The ramises?
This is your
Inferior ramus.
inferior and then
Superior.
superior, and they're joined up at the symphysis pubis. All right, let's go over here at the femur. Head. What is the joint?
Acetabulum.
Okay, so this is going to be the acetabulum. Okay, that forms the hip joint.
Neck.
Neck, and then
Greater trochanter.
Okay. Male or female?
Female.
Female.
Everybody agree?
Mm-hmm.
Female?
Mhm.
Okay, because it's flared,
More round.
large inlet,
Greater
greater
than
than 90 degrees. Yes?
Mm-hmm.
All right. All right. You guys remember the shoulder?
Mm-hmm.
The infrosuperior? Guess what? We also have it for, God, perfect timing, Miss Mitz.
Wait, is she gonna model it for us?
Huh?
My guy hasn't shown yet.
Who's your guy? Tim?
I don't.
Nobody showed up, right?
Somebody walked in. One dude that walked in. Yeah, somebody
Yeah,
walked
there
in
was someone that
earlier.
was gonna come in and then he walked out.
Oh, really?
Well, we were on break.
Yeah.
Where was I?
Grading.
Grading papers.
Yeah, grading.
Okay, I guess somebody did walk in, I didn't notice. All right, remember this?
What do we call it?
We call what?
That.
I haven't gone that far yet, okay? So just like the shoulder, we also have one of the, where's Barry?
Your axial?
I know. I'm very.
You guys know Mr. Siegel?
From the
Mm-hmm.
trash can?
Yes!
I saw that! One of the x-ray techs came and got me and took me in there and I watched him do it.
See, this, I can bring it up, she knew what it
He
was.
totally put her leg up and shot.
Who was it? Who was it?
Who was
The tech.
PIH, I'm not gonna throw him under the bus.
No, no, no.
But, okay, so let me ask you this, how did you,
Graduate
Oh,
or
no,
previous?
he's not.
old school?
No, he's.
Well, he must have been Laura's because
He's a
I
vet.
never
He's
taught.
a veteran. He's a veteran, and he's
He's
like,
a veteran,
"Here, I want to
okay.
show you what the trash can looks like." I'm like, what?
See?
That's called the trash can?
Did
Yeah,
you,
so-
let me ask you this, did you use a trash can?
No, he had me get a couple sponges and a thing, and
Okay.
he just put her leg up.
Okay,
on
then
that.
why not call it sponges?
I think back in the day when they didn't have
We
an
never
extra person.
used a trash can. Oh my God. If you used a trash can, that's just disgusting.
People are-
Anyway.
Especially if their foot fell.
Infrosuperior.
It was in a trash can in a hospital.
Infrosuperior of the shoulder. We also have an infrosuperior of the hip. Okay, so this is where they lift the unaffected leg up, and you're shooting through. We also call this the crotch shot.
I like that one.
What?
It's very much fun.
I'm just so they're not surprised. Okay,
It's very much
it's the
fun.
Trashcan Method. We also call it the crotch shot. So if you hear your text.
It's not a trash.
Okay, the correct term. Okay, the
Louder,
correct.
louder.
The correct method is known as the Danilis-Miller projection.
It's a true lateral. It's a true lateral. That's all you have to say.
It's already in my brain, Doctor.
So
It's already the trash
It's already in my
You
brain.
perpetuate that.
No, I don't have time to do this.
Yeah, okay,
I've got like 100 more images to go
Okay,
through.
look, this is what you use. No trash can or sponges. This is very secure. So find a stool and put it on the table. The patient lays down and then they just put their foot up on that. And if you move it closer, it brings her leg back more. If you move it this way, it brings her leg down and it gets it out of the way. It has stoppers on it so it doesn't slide off the table.
They have no idea what
This
we're
is
talking
what
about
you're-
right now.
Oh, I do. I've already had the visual
Yeah.
Okay,
of,
so you
of
are the
both
only one.
terms.
So this would be great to use. So use that when you're doing.
All right. Infrosuperior.
I'm not going to spell it out.
Infrosuperior projection is generally done on trauma or post-hip surgery. Okay, it's usually done trauma or post-hip surgery. Okay, and this gives you a lateral view of the proximal femur or the hip. Okie dokes?
Yep.
Okay, gives you a lateral view. All right, so let's look at the anatomy. A. Well, first of all, what's B? What's B? So this is the lateral view of
The
the
head.
femur, right? So this is the head. Okay. This A is the
Acetabulum.
acetabulum forming the hip
Hip
joint,
joint.
right?
Mhm.
All right, so from the head we've got the neck.
Greater trochanter.
Greater. Okay, the greater is going to be more superior. Okay, more superior and lateral. Whereas the lesser is going to be inferior and medial.
So that's E then, right?
So that would be, so over here. Okay. And then D is the
Shaft.
shaft. Okay. What's D?
G.
I'm sorry, what's G?
Ischial
Ischial
tuberosity.
tuberosity. Okay. So we'll talk about the inferior superior projection here in just a little bit. Oh, this is what it looks like. Okay. So what Mrs. was saying here is that we have to get the unaffected leg out of the way. Okay, so the unaffected leg is out of the way. Okay. I was showed how to use a trash can to get the leg up and prop the unaffected leg up. That's what we call the trash can method. But we can also use a footstool, okay,
Trash
to
cans have
demonstrate it.
lids. It's not like it's one of those.
Yeah, I mean,
It's
yeah,
a-
it's a prop. And she goes, "You use a dirty trash can?" I said, "No, it's a clean trash can."
It's a medical.
It's a med-
trash.
What's a it's a medical, exactly, it's a medical trash.
They-
All right, but we'll talk about this again in a few. All right. Let's do the sacroiliac and the symphysis pubis. Let me see what we're trying to talk about here. So the joint between the sacrum and the iliac, or the ilium, forms the SI or the sacroiliac joint. Okay. And then the symphysis pubis, we already talked about that, is formed by the two pubic bones. I don't know what else to say about this page. I'm going to keep going. Any questions here, guys?
Mm-mm.
Okay. Yes.
No shielding for the infrosuperior projection. No shielding.
Shielding here?
Yeah.
Well,
Shielding?
male, should we shield? We can't, right? Because
Shooting right through it, right?
their goodies are going to hang out here. It's going to be in the path of the beam, we can't shield it because it will interfere with the image, right? What about females?
Sure.
It's up here, so we can shield females. Okay. But is it effective? Not really, because it's not, when you're shielding them on the top, you're still coming in this way. And so when it strikes the hip, scatter radiation is going to go in all different directions through the pelvic and abdominal area. I mean, you can shield them, but it really doesn't serve any purpose either. Because the shielding is you're supposed to protect them from the direct path. If the shield's on top of their belly, you're not shielding them from the direct path, and you're still forming scatter radiation. Good question, though. All right. All right. So as we had said earlier, in a true anatomical position, the head of the femur is projected anteriorly about 15 to 20 degrees. Again, crucial in understanding this when we're doing a hip radiograph. All right. I'm not going to spend too much time here because I will spend more time with that on the later slides. All right, so we're going to do projections now and x-ray views. We're done with the anatomy part of it. You guys all right with that? All right, so for the femur, we can't get the entire femur on one radiograph, right? Just like the tib fib. At the tib fib, we can at least modify it a little bit to get both joints in there, but with the femur, it's not going to be possible to get the entire femur there on one image receptor, okay? So we break this down into two different parts. We're going to first do an AP distal femur to include the knee joint on a large image receptor, okay?
Oh, that one first?
Well, no, we can do the hip later, but I'm going to start from the knee up, okay? But for the distal femur, you're going to use a large image receptor, 14 by 17, or in this case, 16 by 16, right, in this room. Naturally, what's going to happen is when you have the patient laying on the table, what's going to happen to their feet?
Well, lateral.
They're going to flop off to the side, right? Which also puts the knee in somewhat of an oblique position. So you're going to turn their foot in about 5 degrees to straighten out the leg, okay, to get it in a true AP. So this requires, again, a 5-degree internal or medial rotation of the foot to get the femur in a true AP.
So are we touching epicondyle again?
Not necessarily. I mean, epicondyles of the femur?
Yes.
Yes. Yes, you can. So turn it in and then just palpate for the epicondyles, again, making sure that the plane of the intercondylar area is parallel with the image receptor. Okay. So again, the key here is you want to make sure that you include the knee joint. Okay? Do not omit it. Make sure it's included. Collimate, open up the length of your field to the length of the image receptor, but collimate down to the femur. Now your femur is a bone that goes down your leg. All this other stuff here, this is just fat and muscle. So can you collimate within the fat and the muscle?
Yes.
The answer is yes. Okay? Because the femur is a thicker bone, you really do need to collimate to avoid any type of that scatter radiation degrading your image. Okay? So collimate not just to the soft tissue, but even more into the soft tissue.
And put your marker.
Put your marker somewhere laterally. Okay, you might have to put underneath your leg.
So we open up the full 17, the length, right?
Open the full length, but collimate to the
Tight.
bone, not the thigh. Collimate to the bone, not the thigh.
Can we put the marker on the thigh?
Sure. Don't go by what I say, okay? Because what will happen is once you start your clinical practice, the technologist will tell you exactly where to put those markers. Again, I'm old school and so is Ms. Smith, and we have a hard time understanding this concept of putting markers on the patient. It's hard for us to understand that. Because, you know, your body has all these different grooves and curves and things like that. We're used to just putting it on the image receptor, but the new text will tell you put it on the body. And I don't like that because then you end up having to put those markers in your pocket. It's a dirty thing for me. All right. So here's a femur. We included the knee joint. Okay, rotated 5 degrees medially. All right, collimate, open up to the length of the image receptor, but collimate to the bone, not the thigh. All right, any questions? So that's your AP. This is how we're going to do a lateral. A lateral, you're going to roll them up on their side, on the affected side. So it's going to be a medial lateral projection. This is the normal position. Normal projection is medial lateral. A medial lateral lateral. Okay? So you place the patient on their side. Again, what we're feeling for here is the epicondyles so that they're what with the image receptor?
Perpendicular.
Perpendicular to the image receptor. Okay? Oh, by the way, I want to go back over here. So I'm going to go back here a little bit. When I say central ray, where's the central ray going to be directed?
Mid-shaft.
It's not mid-shaft.
We're gonna divide that.
It's going to be to the center of the image receptor,
Oh, yeah.
not the mid-shaft, right? But yeah, because mid-shaft is here somewhere, so we're centering to the image receptor. Okay, same thing applies here. So you place your patient on the side, open up to the length to the image receptor, again indicative that you include the knee joint. Okay, central ray now, okay, is going to be mid to the middle of the image receptor, not the leg, okay, not mid-leg, but to the center of the image receptor. Open to the length, collimate to the bone, not the thigh muscle, not the thigh tissue.
Because that's in a bucky now, you can't do like the angling the collimation bucket.
I'm not quite sure. I'm not sure. I think it depends on the setup. I think it depends on the setup of the room. I know that you can't do it in the front room because it has to be communicating with the detector. In the back room, I think you can bypass that. So it depends on the setup of the room. Yeah. All right, so that was medial lateral. In a trauma situation, are you going to roll up your patient on the side like this? You can, right? Can you or can you? If they're traumatic. Probably not, right? Okay. So we're going to do what we call cross table. Be familiar with that term. When you say cross table, that just means horizontal beam. Okay, we're going to do a cross table lower femur. So they'll be laying on their side. We're going to prop their legs up very gingerly. You guys ever heard that word gingerly? Very, very carefully. Okay, so you want to lift up their leg gingerly and place some bolster under there, because if their leg was flat on the table, because of the divergent beam, it's going to throw the anatomy past the edge of the image receptor. So we're going to prop it up. Okay? Going to prop up the leg. The image receptor is going to be between the leg. So now we have a lateral medial projection. A lateral medial projection. Okay? Image receptor to include the knee. And this is where, again, there's going to be some differences in your facility. They may use a grid, they may not. Okay? They may or may not use a grid. Being that it's above the knee, should we use a grid?
Mm-hmm.
Yeah, because above the knee, for sure it's going to be greater than 10 centimeters in thickness, right? All right. Any questions here? What's our SID, by the way? We always do, yeah, we do everything in 40 unless we specify it. So this is done at 40 inches.
image receptor has triangulation with the femur, or it's parallel to femur?
Everything's is going to be perpendicular. So it's going to be perpendicular.
It looks like it has.
I know it looks that way. Because again, it's just point of view how the pictures was taken. Okay. So here they were using some kick to hold the cassette up. You have grid holders. You have a multitude of tools that you can use in your department that you can use to hold that the cassette up. All right. Okay. All right. Any questions? Okay, now we're going to do the proximal femur. Okay. Again, how do we know which end to do? Based on what?
Asking the patient.
Area of interest, okay? Now here what they're also doing is they're using a large image receptor. This is non-trauma. Again, if they're a trauma, you can't do this. This is non-trauma. Rolling them up on their side, placing the femur as close to the image receptor as possible. Now, remember I was talking about collimation. So you're going to open up your field to the length of your image receptor. But collimate down. This is all, what is that?
Muscle.
Fat or muscle, depending, right? So you can collimate that off and just focus on the bone. Okay? Now here's the key of importance. When you're placing, because over here it was easy. We say place the bottom of the image receptor to include the knee, right? If we're doing the lateral now, lateral proximal femur, you're going to place your image receptor at the level of, you can feel it, what is this?
Iliac spine.
Your as is, okay? So place your image receptor at the top of your as is, okay? And then center to what? Are we centering mid-femur, mid-leg? Centering at the hip? What are we centering at?
IR.
Image.
Okay, so we're centering at the image receptor. So place the top of the image receptor at the level of the palpable as is. Center to the center of the leg at center of the image receptor. When I say center to the leg, I'm talking about from front to back. Center to the middle of the leg at the center of the image receptor. Make sense? Okay. Now, if it was a male, we can shield them. If it was a female, we can still shield them, right? Because the hip is off to the side, it's not in the middle of the gonad, so we can shield our patients appropriately, but be careful on the shielding not to put it in the way or in the path of the primary X-ray beam. Okay, because we don't want to miss anything. Okay, so use it at your discretion. Okay, any questions? All right, what do we got going on here? All right, any questions? Okay, so that was non-trauma. In this next set of slides, we'll talk about how to get that hip. We actually did already, right? But I'll show you some more pictures. All right, so before we move forward, I want to talk about the anatomical display of the hip joint, okay, based on the relationship of foot position, based on foot position. So when the foot is rotated medially like so, the greater trochanter will be in profile, while the lesser trochanter will be superimposed through the neck. Okay? So internal rotation of the leg, you will see the greater trochanter, but you will not see the lesser. If the foot was rotated externally or laterally, you're not going to see much of the greater trochanter, but you will see the lesser in an external rotation of the foot. Okay, so internal rotation, no lesser trochanter. external rotation, lesser trochanter. Okay.
Does it depend on how many degrees of rotation?
It will. And I'll get to that in just a little bit. But that is a great question. Okay. So here we have true anatomical position. So in a true anatomical position, put it straight up. Looks like it needs one of your feet treatment over here. Okay, so true anatomical position. Okay. The lesser trochanter is going to be well demonstrated. Okay. Male or female? Is it a female?
Female.
Okay, let's call it a female. Greater than 90 degrees, yes. It is a female. All right. Now, when the legs are externally rotated, you even get a better demonstration of the lesser trochanters, yes? But look also what happens to the neck. The neck becomes foreshortened. The neck of the femur becomes foreshortened when the foot and the feet are rotated externally. So yes, you're going to see the lesser trochanter. However, the neck of the femur is going to become foreshortened. All right? Now, when the foot is rotated 15 to 20 degrees, first of all, where did I get that number? Is that an arbitrary number, 15 to 20?
It's the angulation of the femur, the head.
Remember, the relation of the head to the neck is going to be about 15 to 20 degrees. You guys remember that? Anterior projection position. So, to see the neck of the femur free and clear in its true length, you're going to rotate the foot in 15 to 20 degrees. This is what's going to give you full profile of the femoral neck, 15 to 20 degrees. But also look what happens. What happens to the lesser trochanter?
It's almost gone.
Disappears, right? That disappears, but what's in true profile as well?
The greater.
The greater trochanter. So when the foot is internally rotated 15 to 20 degrees, it puts the neck in profile, it puts the greater trochanter in profile. And no longer can we see the lesser trochanter. Yes, what question?
I want to tickling that feet.
You want to tickle the feet? I'll give you $5.
Very nasty.
You wear gloves the whole time.
So I saw one of those challenges online with someone who had really, really bad, nasty feet and diseased feet. So the question was, if they were given $1 million, would you lick the foot?
Yes.
For $1 million?
Yeah.
One lick and set for life.
Then you drink it.
I can't even believe I brought that up. Sorry, guys. But yeah, you guys know what I'm talking about? Those challenges? Okay. I know. All right. Okay, so when you have a patient that presents in your department or the emergency room, because I mean, naturally your foot should be upright like this, okay? If you see one of the feet plopped off to the side, that's a pretty close indication of a hip fracture. Yeah. I mean, it's a good indication, not always, okay? So again, this is normal position of the foot. This is normal. If you do have a hip fracture, you'll see the leg plopping off to the side, okay? Again, usually a good indication of someone who has a hip fracture. So when that happens, don't do anything that you shouldn't be doing and forcing any type of movement or position on that particular hip or leg. Okay? All right. So remember, if it's up or external, you're gonna see a little bit of the greater trochanter.
A lesser.
Okay, I'm sorry, lesser trochanter. If it's externally rotated, you're gonna see more of it. Okay. Now, in true anatomical, in true position, if the foot was rotated internally, what's gonna happen to this?
It's gonna disappear.
It's gonna disappear. Okay. All right.
And that's why the neck is foreshortened, right, on the other
Right.
side.
So whenever the leg is externally rotated, that's where you're going to start getting foreshortening of the neck. Bring it back in, and you will start seeing the neck
In its true
profile.
position.